Hello, everyone. It's really my pleasure to welcome you to the second webinar of the series that's leading up to Geneva Digital Health Day. As Awa just mentioned, Geneva Digital Health Day will take place on the 21st of May in Geneva, but will also be accessible online for the ones who aren't in Geneva at that time. And today's webinar is introducing track number 2, which focuses on resilient health systems. As the last weeks, I think, have emphasized again, around the world, health systems are facing growing pressure from conflict, climate shocks, pandemics, changing demographics, and other crises. And in that context, resilience means building systems that can adapt, continue delivering care, and respond effectively when communities need them most. And digital health has really an important role to play in that effort, helping strengthening coordination, improving access to support decision making, and connect services more effectively. That's why we are really pleased to have a strong lineup of speakers with us today, with Sean from UNICEF, and then solution pitches from Valerio from Touch Health and Tilanka from UNOSA and UN Spider. So I just want to say welcome to everyone. Thank you all for being here. And I'm very much looking forward to learn from these real world experiences today. And then obviously to connect with some of you in the second part, in the networking part. So with that, I'm handing back over to Awa, who will moderate today's session.
Thank you so much, Caroline. So let's start with the first speaker. So Sean Blaschke is Chief of Digital Health at UNICEF. So Sean has been leading a global portfolio around 17 countries, focusing on digital health transformation and health system strengthening. With more than 20 years of experience in global digital health, his career spans from field-defining moments. I'll just give you a few of them. There are many. For example, in Uganda, he helped establish one of the first national digital health strategy on the continent in Africa, driving the nationwide scale-up of DHIS2 and M-Track, and coined them pilotices of course concept. And recently at UNICEF, he's been leading the Center of Excellence during the COVID-19 pandemic, where he supported coordination of global digital health responses across a dozen of countries. Sean, the floor is yours. You can share your slide, and you have 10 minutes for that. Thank you.
Fabulous. I assume all the colleagues can hear me. It's an absolute pleasure to be joining today, and joined by two of our implementers who are going to be talking about these experiences, developing, deploying solutions in an environment where resilience matters. So I'd like to start with some kind of broader framing based on experiences that we've had as UNICEF over the last 18 or 19 years working in the digital health space. So starting here in terms of kind of where are the opportunities, and I assume I don't need to sell anybody on the webinar on this, but we have 4 billion people right now that lack access to essential health services. 14.3 million children received 0 vaccines in 2024, and we have a pretty significant health worker shortage, 10 million projected by 2030. For UNICEF, we see these as children who are unreached, unserved, in large part with a health system that is increasingly digitally enabled, either make or break in terms of, do we get the underlying systems right, or are we going to continue to struggle with systems that are fragmented, ad hoc, incomplete, not reaching the most marginalized, and really missing the opportunity, the promise of digital health. So I wanted to start with a little bit of a retrospective. Awa mentioned this in the introduction, but one of the countries where I cut my own teeth in this space was Uganda. I arrived in 2009, right at the kind of the beginning of the M-Health wave, where partners were coming in, bringing all kinds of new tools, platforms, applications. The government at the time was caught a little bit unaware, and really didn't at the time understand kind of the stakes of getting the governance, the coordination right. And I'll talk about how this matters for resilience, because when you have a space with a a smorgasbord of applications burdening health workers because they've got 4, 5, 8 different apps that they need to be managing, sending information in. If these systems aren't talking to each other, if they're not sustainably financed, it creates a big burden on the health system. And in the case of Uganda, we realized really quickly that this was unsustainable. So the map on the right, which we termed at the time the pilotitis map. I had mapped out about 100 different digital health or mHealth initiatives across the countries. These included many that UNICEF was contributing to, a pilot in the South, a program in the North. And what are the things that I think the characteristics across all these were that vast majority were vertical, donor driven, and siloed. They were focused on a specific intervention, collecting malaria data or looking at TB, and they weren't necessarily aligned with government priorities. What we saw were that each program had their own structures, providing their own training. None of them were talking to each other. And after a couple of years, we started to see successful pilot after successful pilot simply fade away into nothing. In 2012, Uganda stepped in and declared a moratorium. The director general at the time, now Minister Jaina Chang, and said, look, we can't continue on this path. We need to pause. We need to get our house in order. We need to make sure that we have a policy and strategy, governance and coordination structures. We've outlined our priorities, and we've created a space where the private sector, the public sector, CSOs all see a role and a place. And so I think one of the key messages here is that having a single national plan, strategy, roadmap, and framework creates the kind of the rules of engagement, a space for actors across all sectors to come in, understand where they fit in that the country's national digital transformation journey, and can ensure that they're contributing to kind of a common national goal, whether they're working in, again, a small rural area in the north or the capital in the center of the country. Come kind of mid 2010s, we started to see a bit of a shift. There was a large effort by WHO across many regions to establish strategies. In Africa, I think they got about 80%, 90% of the countries by 2018, 2019 to put in place strategies. In 2020, the WHO at the World Health Assembly announced the Global Strategy on Digital Health, which was unanimously endorsed. And by 2023, we had 129 countries with established strategies. Now, what was missing and what still is missing in this space is that many countries, in fact, most of the countries haven't yet turned these into costed roadmaps. They haven't put in place architectures, blueprints to really guide the implementation, the operationalization of this strategy. Right now, we only have 17% of the countries with strategies with structured, sustainable funding models for digital health. Without this, as we've seen in the last year with the ODA cuts, particularly from the Europe and the Americas, without sustainable financing, whether it's domestic financing, innovative or impact financing, private-public partnerships, all the systems in place are at existential risk. Given that 83% of these strategies rely on fragmented or ad hoc financing, they are not going to be resilient for shocks. And what we've been seeing is that many of these systems go beyond nice to have interventions. These platforms are increasingly the core backbone for national health security. They're the tools being used to manage disease outbreaks, health workforce. And so really, without linking financing to strategy, we don't yet have systems that are properly resilient. One of the things that we've seen over the past few years, and these are lessons that have come out both from the Global Digital Health Monitor, an analysis on kind of where countries are on their digital maturity journeys, as well as a variety of other white papers, research, is that really through a systems approach, this is the way that the community needs to move forward. And again, I think everybody has a role in this. Whether you're working with a private sector pharmacy or you're setting up a public sector telehealth program, you have a role in all four of these areas. And so a big push is a shift from the project-based donor-led model to one that is nationally owned, integrated, sustainable, again, with a clear role for private and public sector to engage and participate. And what we're really looking at is in terms of kind of those catalytic systems investments, as I already mentioned, those costed national plans and budgets. But also those architectures, those integrated national systems, moving beyond disease verticals and looking at shared platforms, looking at this through a digital health architecture and DPI lens. Over the last 2 years, or 3 years, this has been one of the most important emerging areas where governments are reorganizing and starting to look at last mile infrastructure, for example, or unique identifiers, not by each sector, but across sectors. And so we need to start re-looking at how we're designing and planning our interventions. Again, if we have a telehealth program and we're trying to track longitudinal data and link it to referrals, we're in many countries moving away from health sector IDs and looking at national IDs linked to birth registration, for example, to provide that linkage, or for financing through unified payment platforms. On the last mile infrastructure in particular, this is one of the areas that UNICEF has identified is going to be one of the most important barriers to address, really to reach the potential, the promise of digitally enabled health systems. What we have on the right with these new digital barriers, about 1 billion people still are served by health facilities with no reliable electricity. And without electricity, we're not going to be able to do very much with these last mile PHC facilities. We have 150 million children still not unregistered, without birth certificates, without IDs. 34% of the countries lack unique patient ID systems. So until we address these areas, again, we will have a bit of a patchwork of systems, stopgap mechanisms that are at risk to external shocks. On the left, this is a map that we have been working with the Ministry of Health in Zambia, Smart Zambia, on helping them put together a national connectivity investment plan. And as you can see here, with this map, there's significant disparities. We have a cluster of districts with 75 to 100% connectivity. Really, consistent, solid access to internet. But others that have between 0 to 25, 25 to 50, and will not be ready to tap into, again, many of the use cases, the pitches that you'll see until we address these last mile connectivity issues. I also like to continuously kind of refocus on the health workers and making sure that what we're developing is going to be enabling rather than burdening them. The paper-based systems of the past are large burdens. Data demonstrates that at least 9 hours, probably quite a bit more per month, are spent by health workers just on filling out paper registries, tallying forms. This is time away from providing care, time stolen from patients. When we do digital right, that information, that time gets returned to the health worker. When we do digital wrong, that burden is multiplied. So really key to make sure that as we're looking at digitally enabling health workers, we do so in a way that frees up time rather than overburdens them. Finally, I wanted to kind of put together a call to action for everybody in this room, where we think partners should be convening. And again, I tried to make these in a way so it doesn't matter whether you're working for a government, a public sector, a private sector partner. One is making sure you're building for systems. We talk about building for people, very critical, but also make sure you understand the systems you work in, the national digital health architectures, use open standards, and contribute to, don't compete with national ownership. look at the long-term funding, the financing. Thankfully, I think with the kind of more and more private sector actors coming in, this is core to your DNA. But for many public sector actors that have been dependent on project-based grant funds, we often only look at digital health programs with very short-term time frames, a 2-year time frame, a 3-year time frame, sometimes even a 1-year time frame. But if we're not looking beyond this, looking at that long-term financing, we're really setting ourselves up for failure. Third thing here is really to coordinate. Key message coming from the UN, from WHO, from UNICEF and partners is that we cannot do this alone. No single agency can succeed. It really takes a village, and it requires coordination and usage of global frameworks, like the WHO SMART guidelines, health information exchange principles, and so on. As UNICEF as well, I would be remiss if I didn't continuously bring up equity and last mile, and building from the outside in. Testing with rural health workers, making sure that the tools can function when power goes out, when devices get lost, in low bandwidth environments, because despite all efforts, things will go wrong, and we need to make sure that when they do, we don't have systems collapse in the meantime. And then finally, really looking at building something greater than ourselves as individuals. So for the solutions pitched today, looking at how does this integrate? How does this add value to not just the target population you're focusing on, but the larger ecosystem of actors? Does this strengthen national systems? Does this address a gap where public sector systems are not able to deliver services? And does this, from that equity approach, really reach every child? Does it close the digital divide rather than reinforce it? So with that, I'm going to turn it back over to our moderator, and I'm excited, I hope, as everybody else, to hear these solution pitches today. Thanks a lot.
Thank you so much, and I think it was very insightful, and I think your 5 principles are going to be also guiding us today during the discussion. So thank you so much for your insightful presentation. So I'm also happy now to welcome our first speaker at the solution pitch. So it's Valayo Parisi. So Valayo is the Chief Program Officer at Touch Health, and he leads the development of implementation of the organization program across Sub-Saharan Africa, with a focus on applying business logic to question of sustainable health access and innovative delivery models. Before that, Valayo actually served as a management consultant at AT, Kearney, and as a system engineer at Alinea North America. So his presentation is about Uberization of rural telehealth in Tanzania. Valayo, the floor is yours. Thank you.
Thank you so much, Awa, and it was very, very nice to hear Sean speak just before this. And I will go through 5 minutes what Touch Health has done and is planning to do. And I think a lot resonates with Sean, and I hope this also sparks a little bit of debate about what can be done about those principles. And we're not getting all right for sure, but I think we're happy to see that we're hitting some of the key elements that Sean was saying from our, let's say, bottom-up approach. Let me just start really quickly, just introducing Touch Health. We have been in Sub-Saharan Africa for the past 20 years, mostly. Many of our programs are built, co-developed in Tanzania. That's our history. And the idea is that what we see is that we want to tackle complex problems, right? And this is because health systems are complex and require simple solutions that actually are holistic. And this is where the concept of telehealth, and I think what also Sean was mentioning, is that we cannot do any solution that is in a silo, we have to take into consideration many aspects, especially the more we go towards underserved populations, the more we go towards the critical problems of the system, the more we have to think about complexity and how to solve that issue. That's what Touch Health does as much as possible with our programs. Now, jumping to what we have been doing so far. In Tanzania, it's been more than 5 years that we have been bringing virtual consultations into the community using community healthcare workers that are already posted in the health system and with a very simple digital solution that is really, think about it, phone calls mostly. And sometimes when we're lucky, we can do video calls, but we're thinking about phone calls that community health workers can make to physicians in the facilities when one of the patients that they visit in the community requests that service. Now, this is something that already happens. We know it happens well in larger peri-urban areas. In the rural areas, it can work, but the key is sustainability, as also Sean was mentioning. So one of the things that we have been testing early on is an at-fee model, meaning how much are patients, even in rural areas, willing to pay for this kind of service that bridges the gap between their village and the closest facility that can be 20, 30 kilometers away from them. And we realized that patients are actually happy to pay a small fee to access this service because that is more convenient to them than actually traveling so long, leaving their farms, leaving their homes. So far, we did almost 3,000 teleconsultations in more than 50 sites across Tanzania. And the data is showing not only that the patients are satisfied, but also that we can discharge patients at that level without requiring them to actually leave. And this is something and reach the facility. So this is something that is the value added that we have already tested. But now thinking about resilience, thinking about how sustainable systems are. One thing that we want to take a look at is how do we reduce as much as possible the costs, because the fees that the patients are able to pay right now definitely do not account for and pay for the entire cost of the system. So how can we be more flexible? How can we create incentives for community health workers to reach the more marginalized? And that's where we are now introducing the concept of this dynamic matching between demand and supply. And this is really about how can we use fractional FTEs, fractional time from doctors that are paid by the teleconsultations that they make when they are available and when they can deliver it, and offer this flexibility also to community healthcare workers and to patients to have access to this service whenever they need it. And this is what CIMU Consult really does. We have developed a very simple e-marketplace that is basically imagine the same Uber app that you have in which there's doctors that can connect whenever they're available, whenever they're after hours, etc., and say, I'm free, I'm available for a consultation. And then there's community health workers on the other side that are reaching patients. And when they have a patient that wants to have a teleconsultation, we match that together. And this is the idea behind what we are testing. We are working within the integrated and coordinated community healthcare worker program run by the Ministry of Health in Tanzania to do this. We're using their community health workers in their communities to actually test this program, with the idea that if we can find a way to empower community health workers to actually link the community to the doctors and the doctors to the community, this is something that eventually has the potential to be sustainable. What we're testing right now is how do these incentives work? How much can we make this system sustainable in the long run? And also working with the government to make sure that we create this regulatory framework that is not existing anymore, in which these teleconsultations really become part of how the health system works and how they serve the poor. So that's my 7 minutes kind of pitch about this, and happy to talk about it and answer any questions whenever anyone has them. Thank you.
And thank you so much, Valayo. I mean, it's very interesting as well. You was also resonating with Sean's presentation and your innovative business model. I'm sure we will have more to discuss afterwards. Thank you. So now the last speaker, but not least, I'm happy to welcome Tilanka. So Tilanka is working at UNOSA, and she is an associate program manager for UN Spider. And one of her main work, she's really working on knowledge management per se, supporting the sharing and uptake of space-based information for disaster management and also emergency response. So Tilanka, the floor is yours. Thank you. You have 5 minutes. We're running a bit behind schedule, but I'll let you do your 5 minutes and then we'll have Q&A. Thank you, Tilanka.
Thank you very much, Eva. Can you see my screen now?
Yes, all good.
Okay. Perfect. Hello, everyone. Thank you very much for having me. It's a pleasure to be here, and thank you also for all of the previous speakers on your very insightful presentations. So I look forward today to talk about the United Nations platform for space-based information for disaster management and emergency response, which is in short UN SPIDER. We are part of UNOSA, which is the United Nations Office for Outer Space Affairs. Now, you may wonder how this all relates to health system resilience. I'll talk a bit more about that in my presentation today. So I'll just give a brief introduction to UN SPIDER. So our main mandate is to really ensure that countries have the access and can use space-based information for disaster management and emergency response. We do that by really focusing on the whole disaster management cycle. So that also relates to prevention, preparedness, response, and recovery. We've been working since 2006, and we have a strong focus on 4 key pillars, which you can see in this slide. So we do a lot of technical advisory support. We go on technical advisory missions to countries. We do capacity building activities such as workshops and trainings. A strong focus for us is also on connecting the link between space agencies and disaster management authorities to really make these linkages, because in a lot of countries we have experienced that they are not connected. And then through this whole process, we, of course, gather a lot of knowledge, and we want to share that knowledge. And for this, our 4th pillar is knowledge management, and we have created a central hub for this, which is the UN SPIDER Knowledge Portal, where we collect, gather, and disseminate all things on how you can really use space-based data and space information for your specific disaster management context. Now, how does it all relate to health systems? Disasters and hazards such as droughts, floods, hurricanes, or storms, they have a severe impact on health systems. They, for instance, can damage hospitals. They often disrupt supply chains to medicines, leaving communities very vulnerable, and they overall increase the risk of disease outbreak. And on top of that, as we all know, climate change is increasing the frequency and intensity of hazards. And so there's really a growing need for health systems to be better prepared and to have the tools to anticipate these risks and hazards and to respond adequately. And this is where space-based information plays a vital and very valuable role. So, for instance, satellites, they can showcase a real-time scenario and picture of what is happening on Earth. So, through these satellite images, we can exactly map where a flood is happening. We can anticipate heat waves or storms and cyclones. And then identify areas that are specifically exposed and vulnerable to these hazards. And so for health authorities, this information is really vital, because only if you get the bigger picture from space and can see on a map which settlements, for instance, might be isolated, can you identify evacuation routes and routes for medical supplements to reach them. Now, what we do at UN Spider is, on one side, we very strongly also focus on emergency response. So that is when a disaster occurs. We support countries in mapping the hazard. Here in the Bonn office, where I am based, we have a strong emphasis on working with the International Charter Space and major disasters. This is an emergency mechanism that has been set up by the Space Agency. And it's a mechanism where countries, once they become authorized users, can activate the charter during a disaster and they will receive freely accessible satellite data. So it's a system which is free of use. And you can get this satellite data to, as I said, to get a better picture of which groups are heavily affected. A recent example we had were the floods in Mozambique earlier this year, where UN Spider supported Mozambique and activated the charter on their behalf to get these satellite images. Now, on the other side, we also work strongly with countries working more on the side of early warning and preparedness and preventative measures, focusing on digital technologies and innovative approaches. So one really emerging approach and solution that we work on is the development of digital twins. Digital twins are sort of virtual model of a real world environment. So by using high resolution imagery, geoinformation and other kind of data sets, we can create this virtual environment and simulation where we can then see which areas are particularly exposed and vulnerable to hazards. We currently have an ongoing pilot study in Tonga where we do that, and we have worked with the government of Tonga. We did a technical advisory mission first to assess really the needs of the region and get all stakeholders in one room. And after that, this initiative has been created also with the CEO's working group on Earth observation. And we created this pilot project to have the simulation of a digital twin. And we, of course, also then communicate this information to health authorities where they can see which critical services might be affected in a flooding incident. I think, as we've also heard from previous presentations, and what is really key is collaboration. So health authorities, disaster management authorities, and also space agencies need to collaborate more and share the common knowledge and data. There's a lot of data that we have and that we can provide to health authorities to have this knowledge and really be better prepared for a disaster, because we know that disasters are going to occur more often. So with that, I also just want to again invite you to have a look at our knowledge portal, because we have a lot of best practices and solution. We have recommended practices which come from our regional support offices who are spread all over the world, and they have these localized expertise. And so they can tell us a specific scenario with what they are dealing with, And it's a step-by-step guide on how you can use satellite data, for instance, to module a flood. Yes, and with that, I'm already done with my presentation. I thank you very much, and I look forward to the discussion. Thank you.
Thanks a lot, Tinanka. I think it's a topic that needs more awareness on. I mean, we are working with the Northside GDHub, so we are more aware of the potential of space technology. But thank you so much for your presentation. We have a few minutes for questions. So I saw a first question, I think it was during Sean's presentation from Annika. So Annika is asking, how can single small players in the system, small NGOs, startups, address the lack of national infrastructure, focus on places where infrastructure is available, or always partner with government and or other big players? Any other ideas? I know, Sean, if you want to take this or any other speakers.
Happy to jump in. And again, I hope this is just an open conversation because I
It
think
is. Yeah.
everybody in this room probably has something to contribute to each question.
Yes.
So Annika, I mean, I think first and foremost, one thing that I would suggest is, see if the country you're working in has a digital health technical working group, a community of practice, some place where partners convene, coordinate, align, and contribute. I mean, this is something that we push all of our UNICEF country teams. We need to be at the table. We need to be sharing what we're doing with partners, and listening and figuring out where we can fit in and support. I would say alongside this, I think one of the things is moving away from kind of a historic approach to addressing last mile infrastructure. Back in my country office days, we would be buying just like data bundle after data bundle of scratch up cards, dongles, running around, giving them out to health workers. You'd see, some with like 4 or 5 different dongles from different partners. And this is the kind of approach that, we need something to fill the gap. We can't wait often for national infrastructure plans to come in. But in the meantime, I think one thing we can do is better coordinate. Are there partners who are looking to kind of pool resources so that each individual program isn't buying a dongle, or solarizing a maternity ward and forgetting the cold chain, or vice versa. And there are efforts to do this, whether at national or subnational, maybe even just through local government. But where possible, work to contribute to the system. It could be just within the primary healthcare facility, but ask those questions. If you're operating there, what other partners are contributing? Are they funding connectivity for the entire facility or part of the facility? How can we coordinate so that it's not fragmented or piecemeal? So again, I don't think it matters how big or small you are. Manage your aspirations. If you're not in a position to change national plans, maybe you can contribute to district or county. If that's not the right level, maybe it's just at a single facility. But I think it's mostly just a mindset shift that there are probably many other partners with the same challenges and problems, and that if we try to solve these by ourselves, we're just going to contribute to more fragmentation. I want to also jump in. I think Carolyn, you had put in a question, or Sophie put in a question around where we've moved in the last maybe decade since some of the early pilotitis work, and I actually think it's been pretty profound how quickly this sector has reorganized. I was a part of a Africa CDC member state consultation in Kigali back in October, and I was shocked. Countries that just the year before, the digital health structures were disempowered, sitting at fairly technical levels within government, suddenly had been enabled, and were reporting directly to a permanent secretary or a director general. I think one of the big shifts was looking at much of the digital health space is an output or a result of investments about 20 years ago, a large part from the U.S. government around health informatics. Digitizing systems was meant to produce data to make donors happy. It wasn't necessarily meant to improve service delivery. It wasn't meant to empower or enable frontline health workers. That's changed over the last 20 years, and you've seen the structures in governments change, where 15 years ago, it was often the HMIS team and then a digital team under HMIS that was responsible for everything, but the lens they looked through was always data, measurement, M&E, health informatics. It's flipped, and now country after country have reorganized. So I'm very optimistic, but it's also bringing in new challenges. I think for those who work in Kenya, for example, suddenly everybody sees the Digital Health Act and the money being pumped in as big business, and so we now have a whole different set of challenges to face. I think no longer is there an issue of governments and development partners realizing the need for enterprise approaches to digital transformation. It's now kind of making sure that I think a lot of the principles, the grassroots principles that inspired many of us to get in the business aren't pushed aside as digital transformation becomes more and more political, more and more well-financed, and the big players start to move in and crowd the space.
Thank you so much, and from Annika, very insightful, and I relate. Thank you so much, and for your insights. Maybe I just want to have a few comments from Ayman. I think it was from your presentation, Valayo. He's asking that is it only for cold case, not emergency one? I guess. Ayman, if you want to, I guess it was for Valayo, your question, right?
Yes, that's right. I'm asking to know, I mean, from what I understand, it's for cold cases and maybe for follow-up cases, but it doesn't work for emergency. What do you think?
Yes, thank you, man. Absolutely. The idea is that, especially working in Tanzania, there are toll-free emergency numbers already available that connect the community health workers. For example, for maternal health, there's a 155 number that already does it. What we are trying to surface is all of the patients that don't have a critical condition, but they're avoiding showing up into the facilities because they do not have time, they don't have money to travel, and then show up much later with complications, with something that could have been preventable. So that's the initial target population that we're looking at. And obviously, community healthcare workers within the training of the Ministry of Health are trained to spot emergencies and to connect to the right system. So the involvement of community health workers is critical to cover multiple angles, and we're giving one tool set to these community health workers, but not the entire one.
Yes, that's clear. Thank you.
Thank you so much, Valayo, for your response to Ayman's point. So now, I mean, I would love to continue discussing with all of you, but we also want to make sure that you have a kind of cozier setting in working rooms to ask your questions. So now, I hand over to Sophie to explain the rules of the breakout rooms. Thank you all.
Thank you very much, Awa, and hello, everyone. So we'll move now to the networking part of the webinar. So we'll have about now 10 to 15 minutes to go into smaller group, about 5 to 6 people. The objective is just to connect and learn from each other. So we will do basically a quick round table. So you each introduce yourself, mentioning who you are, where you work, and you can also add a call to action if you are looking for some support or partners or insight or maybe fundings. Alexi, one of my colleagues, will be automatically assign you to breakout rooms. Normally, we should have one of us in each room, so just to start the conversation. In case it's not, please don't hesitate to start the discussion as a as a quick round of introduction. Then we will be back here just for the closing remarks. Thank you, and enjoy the session. Thank you.
Thank you for wonderful speakers that joined us today and for the engagement of all of you. And maybe Caroline, you want to say a final one? And I hope to see you in May in Geneva for our event coming now in less than 2 months. Thank you all and have a great day. Caroline, you want to say maybe?
Thank you. Nothing to add, just a big thank you to everyone also, as always was very, very interesting. It's so important to, learn from real experience. And it was great to connect with some of you. And I look forward to seeing, hopefully, some of you at the next webinar and at Geneva Digital Health Day in May.
Absolutely. Take care, everyone, mostly, and see you soon. Bye-bye.
Thank you. Bye-bye.
Bye-bye. Thanks a lot.